Welcome to the American Medical Association Physician Education Podcast on the opioid overdose epidemic. Through expert discussions and insights, this podcast will feature information that can help physicians of all specialties address the epidemic of opioid overdoses. Free CME is available. I'm Dr. Bobby Mukamala, board-certified otolaryngologist and member of the American Medical Association's Board of Trustees. Illicit or non-prescribed opioid use in pregnancy has escalated dramatically in recent years, paralleling the increases observed in the general population amidst the opioid epidemic. As a result, maternal mortality reviews in several states have identified substance use as a major risk factor for pregnancy-associated deaths. Physicians are being called to take an active role in recognizing and addressing opioid misuse and untreated opioid use disorder, or OUD, in pregnancy. Challenges persist, however, for physicians balancing their care for pregnant people with opioid use disorder and compliance with mandatory state-based reporting requirements that can have punitive or even criminal consequences. In this episode, we'll discuss the nuances of how we screen, test, and care for pregnant people with opioid use disorder, including the intricacies of mandatory reporting. Joining me in this discussion is Dr. Kara Polin, Associate Professor of Obstetrics, Gynecology, and Reproductive Biology at Michigan State University. She has an interest in educating physicians and physicians in training to improve care for patients with substance use disorders. Her clinical focus is working with pregnant and parenting people and their families. Welcome, Dr. Polin.
Thank you so much. It's great to be here.
Can you share with our listeners a bit about your work in general with pregnant people who are experiencing opioid use disorders before we dive in?
Sure. I'm actually an internist by background. Most people assume I'm an OB, but just sort of fell into treating pregnant people. And I'm really fortunate to work with a fantastic team of myself, a nurse midwife, a recovery coach, as well as a therapist. So one of the things that we really focus on is that team-based care that's so crucial to the practice of medicine in the current stages that we're in the United States, as well as making sure that people have a full, well-rounded clinical care team that can also address their social determinants of health.
Thank you. So I'd like to start with screening for opioid use disorder. So what do healthcare professionals need to know about opioid use disorder screening tools that are validated for use during pregnancy?
So there are specific tools that can be used in pregnancy, as well as tools that can be used outside of pregnancy. This is important because we want to make sure that people who are pregnant get the appropriate screening for them. Some of these tools are geared at specific age groups, such as the CRAFT tool, which can be used in adolescents. And then some are geared specifically towards pregnant people, like the 4Ps or the 5Ps. And then, of course, you can use tools that are not necessarily specific to pregnancy, such as the NIDA Quick Screen. Really, what I tell people is we just want to universally offer screening to all pregnant people. I'm less concerned about exactly which tool you're using because the United States Preventive Services Task Force indicates that there's not one tool that really shines above the rest. So if your system is already screening using the NIDA Quick Screen and that's easy to implement, then go for it. If you have a little bit more ability to pick and choose, you may want to choose a pregnancy-specific screener.
And what do you think about screening for opioid use disorder? Should it be part of all comprehensive obstetric care? And if so, when should that screening in pregnancy begin?
So we definitely, in the addiction space, would love to see all people screened as part of comprehensive obstetric care at that first OB visit, right? If we can capture people with any chronic illness earlier in their pregnancy trajectory, we can do better to improve the health and safety of that pregnant person as well as the developing baby.
And can you explain how urine toxicology testing fits into screening for opioid use disorder in pregnant people? I noticed you didn't mention urine testing as far as validated screening tools, but I know that many people think of urine testing as part of that screening. So what's the role in urine toxicology? What are the issues there?
So it's a little controversial in the OB and addiction interface whether or not we should be universally screening pregnant people utilizing urine toxicology screenings. For the vast majority of people and for the vast majority of institutions, they do verbal screening instead, or verbal screening that may be augmented by or offering urine toxicology screening as well. One way that this can be helpful is by offering the screening with urine as well to all pregnant people. We can get kind of a point in time where we know what's going on with that person. Something that often comes up when we do obtain urine is that as marijuana has become legalized in more states, people are no longer considering it a substance of misuse. So, without specifically asking about marijuana, which does not specifically come out in any of those screening tools as a separate substance, we sometimes miss it. So, that's one place where we might be able to identify people who are using marijuana and maybe not really understanding the risks of long-term development to their child and to their pregnancy. And that can certainly be an opportunity for discussion with the patient.
What would you say some of the challenges are for opioid use disorder screening in pregnancy? What are the ethical questions for screening that need to be considered that you've come across?
The biggest ethical consideration that I've come across is the lack of treatment opportunities in many communities across the United States, which is not necessarily unique to the pregnancy space, but certainly if you're going to screen people to determine whether or not they have an opioid use disorder, we really need to make sure that capacity to treat that population is available in that community. And I really call upon my obstetric colleagues to consider whether or not they might have the competency and the ability to treat people with an opioid use disorder in their general OB clinic, kind of in the same way that, we treat hypertension in primary care and in primary OB. We treat, diabetes in primary care and primary OB. And while there are some people that we still refer to the cardiologist or to the endocrinologist, there may be some people that do need the addiction specialist, but much of this care can be provided in primary care or in primary OB in a way that is much more person-centered than siloing out that care, which also results in more complexity for the patient because now they have to go to two different clinics and see multiple prescribers, and that coordination of care can sometimes be more difficult, just like it is in any other chronic illness. So really embracing the fact that primary OBs are capable, competent, and able to treat substance use disorders is really something that I'd love to see change.
That's such a great point. It seems like what you brought up was an interesting point of the ethics here is knowing the right thing to do, but having difficulty doing the right thing. So not even the ethical question of treatment, but the ability to carry out a treatment plan seems to be a challenge. The ethical concerns for balancing opioid use disorder care for pregnant people with the mandatory reporting and state law compliance can certainly be challenging. What would you say to our listeners to encourage them to meet those challenges and yet advocate as best they can for the best outcomes for their patients?
We all have to live within the regulatory frameworks within our states. However, know that we have a lot of power with kind of those sparkly, shiny letters after our name in engaging with your policymakers, engaging with your Department of Health and Human Services to help them understand what impact some of these community control systems, these family control systems may have on people, particularly in places where there's a very punitive approach to pregnancy-related substance use. Some places even require reporting of pregnant people who are on FDA-approved medications that are proven to improve outcomes during pregnancy. So engaging with those systems as an advocate, I can't emphasize that enough. And also being transparent with your patients on that one-on-one basis. I tell people I have never reported somebody to our Child Protective Services without that person being very well aware that that was happening and why. We are mandated reporters, so we do have to report in compliance with both the laws and the rules in our states, but really being transparent with patients about that so that hopefully they understand why you're doing it, and that you're still there to support them and help them, because I think we lose people to treatment when we don't necessarily report transparently.
Can you tell me a little bit about the role of informed consent in this population and describing how that discussion of informed consent goes?
So, just like when we test for anything that has some of those social considerations, the traditional example that we give is HIV screening in pregnancy, right? At one time, it was pretty controversial whether or not we should be screening for HIV in pregnancy and what the implications of that could be for the pregnant person. Socially, culturally, as well as medically. It's somewhat similar in opioid use disorder. So making sure that the patient understands what they're being screened for, whether it's verbally or with urine, and knowing what the nuances are within each individual state in terms of reporting to Child Protective Services, et cetera, or Department of Family Services, then is really important for us as prescribers so that we can make sure that when we do screen people, when we do have these discussions with our patients, we know what the next steps are for us and we can communicate that to our patients, because the last thing we want is somebody referred to a family control system without them knowing that that is happening.
So shifting gears a little bit from the screening phase to the intervention phase. So depending on the results of that screening and assessment, the next step might be a short intervention for treatment. What do healthcare professionals need to know about evidence-based intervention techniques that may be unique to this patient population?
So in addiction, we often talk about SBIRT, which is screening, brief intervention, and referral to treatment. And that brief intervention piece is really a 2 to 10-minute conversation with a patient, sort of explaining that you're concerned about their substance use, you'd like to help them access treatment, whether that's treatment within your clinic that you can provide or treatment through a referral, and emphasizing the importance of that. There is some pretty good data in alcohol use disorder that for somebody who has risky drinking, so not diseased drinking, but risky drinking, that hearing from their primary care provider that what the healthy drinking limits are and that their healthcare provider is concerned about their alcohol consumption actually reduces alcohol consumption by 50%. I think that people really underestimate the power of a brief intervention and the power that we have wearing our white coats as physicians, as leaders of the healthcare team, have in terms of affecting behavior change in a really short amount of time, and always kind of thinking about what the next step is after that brief intervention, right? We give them this information and we ask them what they would like and what might help support them in making that change, whether that's counseling, whether that's medications to treat a substance use disorder, whether that's a combination of both. That can be really empowering in terms of the brief intervention. And I often hear from people, how do you have time to do that? Just remember that a brief intervention is supposed to be 2 to 10 minutes. We often spend 2 minutes just catching up with our patients, finding out how their family is doing before we even get into the business of medicine.
Yeah, it's such a great point that, I think we feel like because of the statistics around substance use disorder and the toll that it takes in the headlines and the fact that we have a record number of deaths what good is a 5-minute conversation going to do? But I think exactly to your point, when our patient is with us in that exam room and we're talking about all sorts of things, to not have this be part of that conversation seems like a glaring omission, especially because, like you said, the data shows that even that few minutes has the potential to really change the trajectory of this condition. You think that that's fair to say?
I think that's absolutely fair to say. And I think it's also, even if that person isn't ready at that moment, if they have a substance use disorder to enter treatment, acknowledging it and creating a safe space in healthcare is really important to people's long-term wellness and ability to feel as though they can come to us if and when they're ready for treatment.
Mm-hmm, mm-hmm. So let's shift gears to specific treatment options for pregnant patients with opioid use disorder. So what would you say are some of the common misconceptions about treatment options in pregnancy?
So there are a lot of different treatment options in pregnancy, but the one that I really want to focus on is pharmacotherapy. So when we look at opioid use disorder, what the evidence shows is that people should be offered medication to treat their opioid use disorder. Somebody who is on buprenorphine or methadone during pregnancy has much higher rates of retention and treatment for their general obstetric care, and really focusing on making making sure that people are getting that good prenatal care, regardless of where they are with their substance use disorder. I can tell you, I had this patient and I think about her all the time. She was actively injecting heroin. We had her on buprenorphine. And throughout her pregnancy, she kept showing up. And people around me in the office were sort of getting frustrated. Like, she's still using heroin. Why are you still seeing her? Why are you still prescribing for her? She might be diverting her medication, but she'd have the heroin and she'd have the buprenorphine in her system. And she kept endorsing that she did not have the capacity to get to a methadone clinic, which really would have been recommended. And we kept talking about how it wasn't the patient that was failing the treatment, it was the treatment that was failing the patient. The medication was not doing what it was supposed to do. It was reducing her amount of heroin use. It was making her feel better and she was improved, but it wasn't having its full effect. And about 2 weeks before she delivered the baby, she came into the office and she was like, I'm ready for methadone. So we get her into the methadone clinic. I call the methadone clinic myself, get her, same day appointment. We have her cabbed from our clinic to the methadone clinic. They work with her. They decide that perhaps starting right then and there, because of the complexities of the pharmacotherapy with methadone, that you have to reduce the dose, et cetera, might not be a great time to do it right before delivery. And so we agreed we'd kind of continue what we were doing. And I got this beautiful letter. I have it framed in my office. That's how much I love this letter, from the patient about 6 months after she delivered her baby, saying that, she really wasn't ready for methadone, and that if we hadn't stuck with her, she's not sure that she ever would have successfully gotten into treatment. And she definitely did not think that she would still have her baby. So really having that person-centeredness to what we're doing is so important. And incremental success is still success. Having people who are still injecting drugs but are coming for their prenatal care is doing better. We don't tell people don't come back for your prenatal care if you aren't following your gestational diabetes diet, right? If your hemoglobin A1C is not improving after 3 months of pregnancy, we're going to kick you out of the prenatal care. We don't do that in other chronic disease spaces, and really translating that into the addiction space is really helpful. The other really common misconception is that it requires a specialist to treat patients with a substance use disorder. Look, that person who was injecting all throughout her pregnancy, that's a pretty severe substance use disorder, and that probably does need an addiction specialist. But I also see a lot of people that have been on medication for years. And all I'm really doing is, hey, is the medication going well? Things look like they're going well from my perspective. All right, then we'll refill your medication. It's kind of like refilling lisinopril, except with the extra step of it's a controlled substance, so I need to check my PDMP. But it's really not technically difficult. It's just that many OBs haven't had the training to know kind of what the protocols are to check on the medication safety and make sure the person continues to do well. The final thing I'll say is that we don't want to require behavioral interventions in order for somebody to receive medications. We want to make sure that people are offered behavioral interventions, that they are available to them, but requiring them does not improve medical outcomes. So I always tell people we have limited counseling availability in most communities in the United States. And if a person isn't ready for counseling or isn't going to be engaged in that counseling, it's going to be a waste of a healthcare resource. And so maybe we should think about things like motivational interviewing to get our patient to the point where they're ready for counseling, rather than kind of having a draconian mandate for counseling. In terms of overdose prevention, everybody who has a history of an opioid use disorder should have the availability of naloxone, and making sure that that is available to them, and ensuring that there is the ability to have the naloxone both available for should they need it or should somebody around them need it. We know that having more naloxone availability is better for our communities. The final thing I'll note is that the third FDA-approved medications to treat an opioid use disorder is naltrexone, which is an opioid blocker or opioid antagonist. And the difficulty with that medication is it makes it hard to provide analgesia at the end of pregnancy during labor and delivery, because often we use opioids in that portion of labor and delivery. We can kind of tweak some things with methadone and buprenorphine to ensure that somebody can have appropriate analgesia during labor and delivery. So naltrexone sometimes has a little bit of additional complexities to it, and the evidence is not nearly as strong in terms of the benefit of naltrexone specifically in pregnancy as a result of some of these challenges.
Thanks for that. I can't help but to go back to the story of the patient you described and having that moment come where she was ready to go to the next step for treatment with methadone. And she came to you in that moment, and how efficiently you were able to get her into that care that day, it sounds like. And I just can't help but think of what a barrier something like prior authorization would have been. What would you say are some of the special concerns that physicians need to be aware of when starting these medicines in pregnant patients?
Sure. So number 1 through 1,000 is people always ask me, well, to get on buprenorphine, because it's that partial agonist and we're switching from, full agonist, which is an, illicitly manufactured fentanyl, to a partial agonist. What about the withdrawal that the pregnant person is going to have in order to make that transition? And what I always tell people is it's not like somebody has a steady supply of a known quantity and kind of manufactured in a safe facility when they're getting their illicit fentanyl. So these individuals are likely going in and out of withdrawal throughout the day. So being aware that that's the reality that people with a substance use disorder are living sort of puts that risk of withdrawal at ease. And remembering from a fetal development standpoint that unless they're in the 3rd trimester, the baby's nervous system isn't developed enough to really feel, quote unquote, the withdrawal. Often that's something that is very reassuring to my pregnant patients. And that can be very helpful in terms of getting them to buy into starting the medication. Different people require different amounts of support. So certainly I can tell you many stories of people who come into the clinic and, the question I ask them is, have you ever started buprenorphine before? That, the Suboxone is the combination product. But have you ever started the buprenorphine before, whether licitly or illicitly? Do you feel comfortable doing that at home? And how can we best support you through that process of starting the medication, which in addiction we call an induction, but I've learned not to tell people in the OB world that I'm inducing somebody at, 20 weeks. I know, not surprising that raises some red flags. So doing the medication start and find out what that person's comfort is with a medication start at home versus coordinating with my OB colleagues for an inpatient medication start, which usually my indications for that are some sort of other reason that maybe I'm concerned about the person. Maybe they don't have good social support, so I'm not sure that they'll have somebody who's able to help them through getting to the point where they can start the medication. If they're in that 3rd trimester, I will usually at least run it by one of the obstetricians in the office to see if they maybe see something else in the patient's chart or the patient's pregnancy history that as a non-OB, I may not be aware of that could put that pregnancy at risk. And it really just making sure that you're there for people. The other biggest indication is I'll have somebody who maybe tries starting the medication at home and for whatever reason is not successful. So I had a patient who came in, her significant other was with her. She thought she'd be able to start the medication at home. She went home and it was, 50 questions for the on-call physician who isn't an addiction expert. So I end up getting the call. I'm on the phone at night with her, trying to walk her through the induction. She comes in the next week. It wasn't successful. They decide they have a whole bunch of questions. We talk it all through again. They try again. It's not successful again. So I kind of to and through is what I tell people. If we struggle with 2 home medication starts, then maybe we should think about the hospital-based one and really really having those procedures in place with the inpatient obstetric team to ensure they're comfortable with starting the medication. We definitely use what they call the COWS scale, the clinical opioid withdrawal scale, in the hospital to help support some of that medical decision making. But there's also a SOWS scale, which is the self-administered opioid withdrawal scale. So making sure that patients have that when they go home so that they have a little bit of guidance in terms of when they might be ready to start the medication can be very helpful.
Mm-hmm. Can you talk a little bit about the risk of neonatal abstinence syndrome for newborns or NAS for people who use opioids or medications for opioid use disorder?
Sure, absolutely. We talk about this all day, every day in my clinic. So people are often very concerned about NAS, and appropriately so. Nobody wants to see their baby go through withdrawal, especially not somebody who has gone through withdrawal themselves, because it's not comfortable. The books always tell us that it feels like the flu. I always tell people it feels like the flu with the worst insomnia of your life. And I don't know if you're like me, but if I have the flu, I want to go into a dark, quiet room and sleep. And it's miserable if you can't get that rest and get that sleep. So people know that that's what it feels like, and they don't want their baby to suffer as a result of their opioid use. So many of us have transitioned to something called Eat, Sleep, Console, which is a very family-centered approach to the treatment of neonatal abstinence syndrome. And it really puts the parents and the other caregivers that have been around the pregnant person at the center of treatment, which is shown to markedly reduce the need for medications compared to something called the Finnegan scoring, which is what we used previously and was developed many, many decades ago. So we've updated that to something called Eat, Sleep, Console, and it's kind of what it sounds like. We monitor if baby can eat, whether breast or bottle fed. Babies who are breastfed by moms on MOUD are less likely to suffer NAS, and it's not actually related to them getting any opioid through that breast milk. It's really just that physical closeness and that skin-to-skin contact that tends to be just that much greater when somebody is chest feeding compared to when somebody is bottle feeding. And then sleep is, can the baby sleep like a baby sleeps for about an hour at a time? And can the baby be consoled when they cry? Because all babies cry. Are they consolable through things like swaddling, shushing, skin-to-skin contact, care by the folks that have been around them, by the pregnant person and their support network? And a big thing for people is really understanding that NAS is a time-limited intervention. Babies that have NAS are not doomed to some sort of long-term sequelae. And one thing that I'm constantly talking to people about is most withdrawal occurs in the baby between days 3 and 5. So really early withdrawal, things that happen within like the first 24 to 36 hours, it's actually more likely to be the result of nicotine withdrawal than it is the medications for opioid use disorder. So encouraging us not to blame everything on the MOUD is kind of something that I often see. And in terms of success with Eat, Sleep, Console, as much as we can room in and not separate that care, those adult caregivers from that newborn can really impact and reduce NAS risk.
Thank you. Are there psychosocial support services that help support pregnant people with opioid use disorder? And if so, can you tell us a little bit about those and their role in taking care of patients?
So there's definitely a lot of counseling systems available. Many communities have programs specifically for pregnant people with substance use disorders that typically consist of a recovery coach as well as a counselor who can kind of meet that person within their community. Those are often run through community mental health organizations or other behavioral health counseling service organizations and differ state by state. The other big program that has sort of analogs in many different states, as well as the fidelity to the original program, is something called Nurse Family Partnership. And they've been expanding into SUD prevention treatment as well. And they provide direct nursing support out in the community from pregnancy and through part of the baby's first years of life. And what I love about NFP, and this is a data point that's outside of substance use disorder, but for the program in general, is that grandchildren of grandmothers who were in NFP have higher high school graduation rates. So really knowing that when you treat that pregnant person, you can have impacts throughout their family tree, even, skipping a generation beyond is really impactful. So if you do have those resources in your community, making sure that you have relationships with them and referring to them robustly can be helpful. And I like being able to refer to both counseling service as well as to nurse care management services, because it gives my patients choice in terms of what might work best for them or what might be most appropriate for them. And as a bonus, many of these programs also have access to things like car seats and other safety equipment for patients.
That's a great resource. Thanks. What about harm reduction strategies in pregnancy? I mean, it's getting a lot of important attention now in general for patients with opioid use disorder, but what are the nuances of harm reduction in pregnancy?
I think what I like to talk about when I start talking about harm reduction is that is so much of what we do every day in medicine, and we just don't call it harm reduction, right? How many of us have seen that patient with hypertension and we have the conversation with them about the importance of taking their medication, the importance of diet and exercise, the DASH diet, reducing salt intake, all these other lifestyle things, connecting them with a nutritionist to talk about the DASH diet, to implement some of these healthier behaviors, maybe connecting them with other resources in your community that can support some of those social determinants of health changes, right? Some of those lifestyle changes in their world. But when we talk about substance use disorder, somehow we turn that into harm reduction. And we call it something very, very specific. And really, we're just doing the same thing we do in every other chronic disease state, which is meeting the patient where they are, trying to help them through stages of change to make healthier lifestyle choices. And how do we best do that? I think it's by utilizing motivational interviewing. How I got into addiction in the first place was I was planning on being a primary care doc, and I fell in love with motivational interviewing and thought, what a fantastic tool. I can help my patients with their engagement with healthcare, with their engagement in these lifestyle changes that are so hard for us all as physicians to kind of wrap our heads around and get our patients to wrap their heads around and share that vision of what that looks like for them. So how do we look at harm reduction and addiction through a similar lens and just understand that change is hard for all of us? And when we're looking at that pleasure reward syndrome, we're looking at things that impact it profoundly with the disease of addiction. It's kind of the commonality is that all these substances somehow alter the response of the pleasure reward center. How do we support our patients, and how do we look at harm reduction as just part of what we need to do in medicine? And so if somebody is pregnant and they're still injecting heroin, making sure that they have access to safe syringes is sort of the same thing to me as somebody who has diabetes and needs access to safer, healthier food, getting them connected with WIC. And so how can we change that frame into looking at harm reduction as just part of what we do as medicine, and in this disease space, making it no different than other chronic illnesses?
Thank you. And such a great reminder of that double standard that you just illustrated so nicely that exists in treating patients with substance use disorder versus everything else. Shifting gears a little bit to post-pregnancy. So I imagine that continuity of care post-pregnancy presents its own set of challenges. So how do physicians build strategies to mitigate these barriers to treatment postpartum?
So we know for the pregnant person who delivers their baby, the highest risk period for them in terms of substance use related deaths is actually in the 4 to 12 months postpartum. So these transitions of care are so important for the health and safety of people who have been pregnant. In my clinic, we'll actually keep people for up to a year. So I'm really, really lucky. However, I know that most obstetric clinics is kind of that 6 to 8 weeks time period. In our clinic, because we have the carrot of the buprenorphine, we actually have about 80%, sometimes usually a little bit higher than that, of our patients actually attend their 6-week postpartum visit. And for the non-OBs in the audience, the traditional kind of OB overall rate is between 40 and 50%. So we do see a lot more of our patients at that 6-week postpartum visit. I tell people that I don't want a warm handoff. I want like an I just burned my hand in the oven handoff. So I have a group of addiction docs that I can transfer to. I have some primary care physicians that will take kind of those chronically stable patients. And when we look at that transition of care, we really want to make sure that people don't get dropped, that if for whatever reason they don't get to that first appointment with their next provider, that they know they can come back to us and have another prescription or have another office visit while they reschedule. I tell my patients that there's no situation in which I want you to not have a prescription because we failed as a healthcare system to get you from one place to another. And I also always tell them, sometimes things pop up when you have a newborn and you can't make it to that appointment, like the baby gets sick, or you just really had a terrible night and you just can't get yourself out of the house because they also have a newborn. And so just really making sure that people know that we want that like 350-degree oven transfer and making sure that they have that and ensuring as much as possible that somebody stays in their life, whether that's nurse-family partnership or an analog counseling services, so that we have a continuation of some of those services, as well as making sure that any sort of wraparound services that they have around housing, food stability, employment are aware that this transition is happening so that that person has a full suite of support. As one thing changes, not everything is changing all at once. And where there's the ability to be flexible, if their therapy has to change, can we hold them onto them for a few more months or vice versa to really coordinate that amongst us all as care providers is really, really helpful.
And are there special concerns with postpartum depression in patients that have opioid use disorder?
So people who have a substance use disorder are at higher risk for any type of other mental health concern. So we actually do a quick check-in with our patients. We do it via telehealth at 2 weeks postpartum. One of the nice things about rooming in programs that monitor that baby through Eat, Sleep, Console is that Eat, Sleep, Console lasts for 5 days. So you actually still have the pregnant person in the hospital on day 5, which is when the normal baby blues happen. So we get an extra screening of that pregnant person, that postpartum person at 5 days postpartum when baby discharges. And if there is a concern on the depression screener, Edinburgh or PHQ-9, then they will contact the office and we have that information. We can support that person. Our social worker can call and make sure that things are going okay as they transition home. And then we do, like I mentioned, a quick 2-week check-in where we're just making sure that everything is okay, they have their medication, and they feel comfortable before we do that 6-week check-in.
And how do you counsel patients with opioid use disorder about future pregnancies?
So we definitely want to counsel them, as we do for all folks, about interval between pregnancy for kind of the pregnant person's body to recover. And then we offer all patients contraception. We do a lot of IUDs in our office, but whatever that person is interested in, and making sure that they, continue to understand that what the evidence really shows is that stopping the medication before the next pregnancy is not necessary. And really, we want to continue to support them in their chronic illness. And if that includes medications, to stay on those medications. And as with many pregnancies, not all of them are planned. So just welcoming people back should they get pregnant again, whether planned or unplanned, is really important to us.
So we've only had time to really scratch the surface of a very complex topic. And as we bring this discussion to a close, what would you say are the main takeaways that you'd like our listeners to remember the most?
Really treat people with a substance use disorder the way you do other chronic illnesses. if you don't have the comfort and capacity to treat substance use disorder, kind of those mild and moderate disease states, consider what that would look like in your clinic. And there are lots of national supports that can help you with implementing that in a general OB clinic. And really just remembering that people with a substance use disorder are not unlike any other pregnant person. I tell people all the time, I've yet to meet a pregnant person that isn't doing something to change their healthcare behaviors in order to improve outcomes for that pregnancy and for that baby. And my patients are no different. It's just that they have a really complicated disease that we don't always know how to treat. And really just being kind is going to go a really long way.
Dr. Pullen, thank you so much for your work and for joining us today.
Thank you.
And thank you to everyone for listening, and we'll see you next time. Thank you for listening to the American Medical Association Physician Education Podcast on the opioid overdose epidemic. Make sure you tune in to other episodes of this series to learn more about opioid use disorder, and harm reduction. Visit the Resources tab to learn more. Complete the quiz to earn CME.